Good morning, everyone. My name is Sarah Sutka from the University of Washington and the Fred Hutchinson Cancer Center, and I have the distinct honor of chairing the SRG for the Bladder Cancer Advocacy Network Patient-Centered Clinical Research Young Investigator Award. This award is unique in that it supports early career investigators and researchers who are investigating transformational, patient-oriented research. We seek proposals that span the critical topics such as access to care, quality of life, patient-reported outcomes, access, equity, and health disparities, as well as comparative effectiveness research and survivorship. It is my true honor, and I'm delighted to present the 2022 awardee, Dr. Ava Saidian, who's going to present to us today on her work looking at disparities in patient-reported outcomes among Spanish-speaking Latinx patients with bladder cancer. Dr. Saidian recently completed her fellowship at the University of California, San Diego. She earned a BS previously at the University of Texas and her medical degree from the University of Kansas School of Medicine before she was inducted into the Alpha Omega Alpha Honor Society. Prior to that, she completed her residency at the University of Alabama at Birmingham, and we're truly excited to hear about your work today. Thank you.
Thank you for the introduction. So like Dr. Sutka mentioned, I'm going to talk to you today about our study titled Disparities in Patient-Reported Outcomes Among Spanish-Speaking Patients with Bladder Cancer. So I started this project as a fellow at UCSD, and I hope to continue it as a faculty member at the University of Tennessee. So just some background information. The incidence of bladder cancer in the Latinx population is lower than the general population. However, this group tends to have worse survival outcomes. The details surrounding their survivorship is unknown. There's not a lot of studies or data related to survivorship in these bladder cancer patients. There have been other widespread studies that have found that even minor language barriers can affect the quality or type of care a patient receives. An example of this in bladder cancer was a study done in Texas by Dr. Wu's team where they looked at just different outcomes related to bladder cancer care. They found that Latinx patients, when corrected for other variables, were less likely to receive a continent diversion. So neobladders or a pouch were more likely to get an incontinent diversion. There's obviously a lot of factors that lead to that, but one of the major things that they postulated was that a lot of this was due to language barriers or things that relate to language barriers, such as inadequate patient counseling by the physician or just not understanding patient-centered preferences, as they had a provider who had different, who might not understand their unique cultural beliefs. So we know that there are disparities that exist in cancer care, not just bladder cancer, but other cancers between different ethnic groups. However, disparities in health-related quality of life outcomes in the Latinx population compared to the non-Latinx population has not been well described. So that's what we sought to do. Given we're in San Diego, we have a very large Spanish-speaking population. So we designed our study around three aims. We wanted to establish if there was a true disparity in quality of life outcomes using patient surveys. We wanted to interview patients to better understand their perioperative experience, and then we wanted to translate a decision aid into Spanish so that we could hopefully start to bridge the gap in care in this population. So we used a number of different surveys to try to establish any disparities in this group. Before I get into all the surveys, I do have to mention a huge problem that we faced was a barrier to patient recruitment. I was kind of naive and I thought, oh my gosh, we have so many Spanish-speaking patients. This is going to be great. We're going to solve all the world's problems. However, you can't do that if patients aren't participating in research. There were a lot of different barriers to recruitment. Some things that stuck out were not having phone access or email access, which is how we did the surveys, or their phone access was inconsistent. They were elderly patients who their main contact was their child who worked all day, so we had difficulty just communicating with the patients, or they were just not interested because they felt like it was a large effort and they didn't want to burden their family by participating in the study, which is all very understandable. Okay, so anyways, back to the surveys. So the first survey that we use is the Bladder Cancer Index. It's 36 items, and it covers 3 different domains: urinary, bowel, and sexual health, divided into function and bother. I'm sure all the clinicians might be familiar with this. A higher score relates to a better health state. So again, we had a super low response rate in our Spanish-speaking population, so all of our data was not statistically significant. However, there were some trends. Primary English-speaking patients tend to have higher scores, so a better health state in terms of urinary function, being less bothered by any urinary symptoms. Same with bowel function, and they were less bothered, and though they reported worse sexual function, they were actually less bothered by it. Again, none of it's statistically significant. Hopefully we can make some more concrete statements once we recruit more patients. So our next survey dealt with body image. Some background on that. We know anecdotally as a physician, we can only imagine the changes to the body that happens as you undergo bladder cancer treatment. There was a prospective study done recently looking at health-related quality of life outcomes between patients who received neobladder versus ileoconduit. They found that there weren't actually that many differences in the long term, except for in a couple in 2 domains. One being in body image. They found that patients who received an ileoconduit had worse or a greater decrease in their self-reported body image compared to those with a neobladder. So they gave them the survey baseline right before surgery and then at different time points afterwards, and the patients who received an ileoconduit compared to a neobladder kind of had lower scores in the end. The way that they did this was using a survey that had just 3 questions relating to body image, which you can see here. We wanted to use a tool that was a little more robust, and so we used the body image scale. It's a 10-point survey relating to body image. It was initially developed for breast cancer patients, and it has only been validated in breast cancer and colorectal cancer patients. So we thought this was also a great opportunity to not only see if there was a disparity between these different ethnic populations, but to also validate this survey so that other clinicians could use it in their studies. For example, like single versus multi-port. Do patients actually care about cosmesis? Is there a difference? Things like that. So a higher score correlates to a self-reported worse body image. Again, we had super low responses from the Spanish-speaking group, and none of our outcomes were statistically significant. But we did begin preliminary validation. We established reliability, face and content validity. That's all just boring stats talk, but basically those are weak forms of validation. What we really want is clinical validation, so other people can use this, which we've begin starting that validation process. And as we get more participants, we should be able to establish validity of this survey and being able to tease out how patients feel about their body image based on different subcohorts. And then our last one was satisfaction with decision. Again, we gathered a lot of preliminary data on how patients felt about their decision to have an ileoconduit versus a neobladder, and then break down on different subgroups. There was some small differences. English-speaking patients were happier with their decision. Neobladder was, just barely slightly higher. Again, none of this was statistically significant. So the second part of our study was patient interviews. This was a really unique experience. A lot of what we learned is probably stuff that patients, patient advocates, and patient family members know. As a clinician, I personally don't get a lot of time to talk to patients about their quality of life. Our 15-minute visit is usually spent talking about the state of their cancer, our next treatment options, going over any issues they might be having, but not really quality of life. So getting to spend an hour with patients just talking about their quality of life was really interesting, and I hope some of the things I learned can help other people with their patients. Again, we had no Spanish-speaking patients that were interested. We're still trying to recruit to see if there are any, different themes that emerge from our Spanish-speaking population. But our interview was divided into 3 different phases, so preoperative, perioperative, and then long-term phases. In the preoperative phase, we asked, how did patients feel going into surgery? Did they feel like it was the right decision? Did they have confidence in their team? Everyone, most people felt that they felt confident it was the right choice to undergo surgery, and they said that this confidence came from not only family support, but mostly from their urologists and their medical oncologists. So just having confidence in their team gave them confidence into going into surgery. Otherwise, the patients who didn't feel confident in their surgery decisions felt like they had, they were happy they went through the surgery and that they're doing okay with their cancer, but they just seem to dwell a lot on, should I have done this? Was this the right thing? Did I have enough information going into it? Then we asked patients, what resources did you get preoperatively that helped you decide between an ileoconduit or a neobladder? So there were a couple patients that were told that they should get an ileoconduit just based on their comorbidities and their cancer. Otherwise, most patients said that they just received a handout describing the differences, or they saw an ostomy practitioner who, helped them better understand an ostomy. Otherwise, it kind of ranged from patients not really knowing what they were going into, just blindly trusting their physician, versus others doing research on their own. And I think what was really interesting was that videos were really helpful, which makes sense when you think about it, but in a clinic visit, getting those resources to a patient is not always at the top of your head. So I really like what one patient said, which is, I watched a YouTube video of someone changing a bag. They made it look pretty easy. I saw it before surgery, and it helped me feel very confident seeing someone do it. It was more helpful than the cartoons or the people with fake plastic stomas on. I didn't know people did that. That's interesting. So immediately post-operative, we asked patients, was there anything notable about their time in the hospital? Most patients said it was fine. They were happy with their nursing staff and their clinical staff, and there were no issues. Only notable things were patients who had complications, which is understanding. A patient had, for example, a UTI, had a indwelling catheter for a long time, and is now having issues with continence of their neobladder. So they say that they, think about that time a lot. If there's anything that should have been done differently, is that why I'm incontinent? And then, another patient, which was kind of eye-opening to me, we deal with ileuses all the time. If I tell patients, if you're getting a cystectomy, you're probably going to get an ileus. We just plan for it mentally. This patient was funny. He said, all I remember about the hospital was dreaming about Diet Coke and ice while they had their NG tube in. So patients are really residual. I'm sure you are really strong in what they have to go through. I can't imagine having to. Anyways, okay, so learning to care for their urinary diversion. We asked them, what in the hospital made you feel confident in going home and caring for your urinary diversion? And most people said, having practice. They might have changed it once or twice in the hospital with the ostomy team, but they had a family member there who was doing most of the changes. And the thing that really helped them become comfortable with caring for it was when they got home, managing it themselves, whether that was flushing their neobladder on their own or changing their own bag a couple times and making it part of their daily routine. Okay, long term, so what's it like living with a urinary diversion? Most patients said that it's just become a part of their daily life. They've learned to adjust. Some people had to make more adjustments than others, but they feel like they live a normal life. A lot of the patients with neobladders who might have to catheterize mention that their day revolves around catheterization, but they've kind of learned to live with it. Activity, so it was really reassuring hearing how active all these patients are, even though some of them have recurrences of their disease and are currently getting salvage therapies. They say they still live an active life. I walk every day, I live a normal life. Most people's limitations in San Diego was just that they don't surf anymore or go swimming, but they've learned to kind of live with that, which was great. This one really surprised me, actually. So when it came to sexual function, most of the men reported, having no erections post-operatively, but they said that that was a surprise to them. They did mention that, okay, my surgeon probably brought that up, but I wasn't really thinking about that going into a cancer surgery, but they were just surprised at their lack of, any erection. All of them did mention that it's not a big deal. They found other ways to be intimate, or they're not sexually active. However, they just were really surprised by that. So, just a reminder that there's so much going on before surgery, but these things just have to kind of be reinforced to the patient who has so much going on. And then another interesting thing that came up was a patient who had a total hysterectomy as well as an oophorectomy, and that put them in menopause. Functionally, they didn't have any sexual issues, but the bother came from the fact that they were incontinent and they didn't feel comfortable being with a partner while they had overnight incontinence, which really kind of, there's more to it than just hormonal and like vaginal length and things like that. There's a lot that goes into feeling sexually healthy, which was highlighted. Okay, emotional mental impact of bladder cancer. I stupidly asked patients, so was there an emotional or mental impact of your bladder cancer treatment? Yes, there was. But more interestingly was how they dealt with it. So a couple themes emerged. A lot of patients said they started to feel normal, or, like they had less of a mental toll once they started getting back to their normal life, doing their normal things, being kind of taking care of themselves. Other patients said reaching out to mental health counselors was very helpful. Having a supportive family or spouse was also very helpful. And then I thought another really beautiful thing that came up a lot was the importance of a support group. So meeting other patients who have gone through a similar thing was really helpful. Patient mentioned how they had an instant bond with people they just met because they have gone through this really unique experience, and how that really changed how they live with their urinary diversion. Impact on body image, there was a spectrum of responses. Some people said there was no impact at all. Other people said looking in the mirror, they didn't even recognize themselves. They didn't know what the stoma would look like, things like that. And then how they're coping with it also kind of varied as well. Some people just had to make changes to their wardrobe or things like that, and other people are, still having issues coping with the changes that their body goes through after bladder cancer treatment. So then we asked advice that they would give other patients or what they wish they knew from the start. There was also a lot of gems, which we'll hopefully dive into more once we publish a manuscript, but real quickly, some important things as a clinician that stuck out was patients mentioning bringing things up to your medical team if they have any doubts, which really highlighted for me the importance of creating a space where our patients can be vulnerable, because if my patient has a doubt in their treatment or even in the treatment I'm going to provide, we want to create a space where they can bring that up and we can help them work through those doubts or get them the resources they need to feel comfortable with what we're going to do. Other patients, most all patients said, I want patients to know that they're going to be okay after, they're going to live a normal life. It is a big adjustment. Other people stated the importance of communicating with the patient and also finding support. Support groups, support in their family and friends. And then another thing that I think was important to highlight as a clinician is a patient says, you're overloaded with the whole scenario, you have all this information coming at you, and you might be hearing fatigue and incontinence, but you don't know what that looks like. And once you're home and the Foley's removed, it's a surprise. So it just highlights, I have a spiel that I say before surgery, and I know I cover all of these different things, but it's just a reminder that you might be saying it, but patients aren't hearing it because of all the different things going through their mind before bladder cancer treatment. So that at all phases of taking care of your patient, it's important to bring these things up so that they know what's normal and what's not, and what to bring to your attention during their recovery. And then real briefly, so the last part of our study was translation of a decision aid. There's currently only one written decision aid that helps patients decide between types of urinary diversion when going into a radical cystectomy. It is only in English, and there's no Spanish translation. So what we first did was we modified it so that the reading grade level and the ease of reading, or it had an easier readability score so that it could be more widely applicable to different patients. We then had 2 Spanish-speaking physicians or clinicians translate it into Spanish. We then took those 2 separate translations and reconciled it into one. A Spanish-speaking clinician did that. It was back translated into English compared to the initial English translation to make sure there were no mistranslations. And we're currently sending it to different Spanish-speaking urology patients for review to make sure it all makes sense and it's understandable. Once that's done, we'll be able to pilot test it and hopefully be able to publish it by early 2024 for use in clinical practice. So a lot to summarize, but in short, we won't be able to understand disparities that relate to ethnicity or cultural disparities until we're able to better involve these patients in research. And then also, we learned so much from the patient interviews, but I think the main thing is that supporting your patient pre-op, peri-op is just as important as their long-term support. So getting patients those resources is important. So thank you to all of you for listening to me ramble about this. A special thanks to all the patients that participated. Beacon for helping us get this project off the ground. My mentor, Dr. Salmazi, who we're accidentally matching today. All of the patient advocates and our research assistants that helped. So thank you.
Very nice presentation. I have one question and one comment. Let's start with the comment. Being married to a Spanish lady from Spain, brought up in French, over a couple of decades now of experience, I've seen time and again that people speaking language will speak with an English speaker, and then I'll be told, oh, they don't want this, they didn't understand that, they don't want this and this. Then you come in, speak even with people sometimes who are fluent. People are scared at the time of their diagnosis. They kind of lose their skill set. And simply having people who speak, and Spanish is such a huge language culturally, is so important. So I think it puts the emphasis of having people really speaking. And French Canadian, for instance, are very fluent in English still. When it boils down to the conduit, to those nitty-gritty of the details, they really prefer to have the conversation in French. That's really. And then the question was whether when you approach those patients, and you said that unfortunately it was a little bit disappointing in terms of response. Were these approaching by emails in Spanish? Was this exclusively in Spanish, or was it that you sent an email in English and then sometimes, unfortunately, no one answers?
We initially approached them by calling them. One of our clinical research assistants is a primary Spanish speaker, so she would call them. And then also the emails we sent out were in Spanish as well.
Okay. Nice work, and certainly worth furthering.
Thank you.
Nice work, Ahmed Mansour from UT San Antonio, and such work is very needed in patients in populations where the Latino percentage is high. My question to you is, what are your plans on coding the qualitative data that you're going to get from the interviews, and how are you going to incorporate that in addition to the survey data, which are already validated? There are many ways of coding this free text that you get from interviews, and I would like to hear your thoughts about that.
Yeah, so there's a lot of data on patient interview and focus group analysis. So what we have the free text data, and there will be independent reviewers, 3 of them, who will go through that data and find thematics, and then that will be kind of combined. And so those are just themes that popped out to me and my mentor, but there's a systematic way to review it, which is how we'll do that.
And more recently now, there is an AI-generated system that can help instead of having...
Yeah, exactly. Yeah.
Good work. Nice work.
Oh, thank you so much.
Hi, Armin Smith here. I thank you so much for the very insightful presentation. I have also a question and a comment. So the question is, it seems like there is a little bit of a theme, these patients were not really good responding, they were not interested in one-on-one interviews. So having done this, what do you think is the best way to engage our Latino patients for clinical trials? Is there something you think that is more effective, less effective?
Yeah, I think, the patients that we did involve, it took a lot of effort in the sense of repeat communication with them. So calling them, they say, I'm interested, call me back later. So just kind of a lot of man or woman power in terms of just following up on these patients who live busy lives and aren't going to follow up to an email on their own. And then I think a really big tool will be recruiting these patients in person. A lot of these patients are a few years out from their cystectomy, so their follow-up in a urology clinic was just annually. So I think just kind of coordinating that was hard just with our limited resources. But I think in-person recruitment will be a big deal. And what one of our patients said on the panel, kind of something that we'll probably try to do more, is reach out to the community. In San Diego, there are support groups for, like Spanish-speaking patients with breast cancer and things like that. There wasn't one necessarily for bladder cancer that I found, but I'm hoping in different communities that might exist, or, through churches, things like that. So kind of going into the community more to recruit patients.
Yeah, and the comment I had was, I think it's not just a language barrier, I think it's also, a lot of it's very cultural. I've noticed in patients that I've taken care of that were of Hispanic descent, there's a lot of trust in the doctor, and there's not a lot of dialogue back and forth. They just want to hear what you recommend, and they want to, go with it. So I feel like every time I try to enroll a patient in a trial, I feel like, are they doing it to please their doctor, or are they really interested? So, it's just something that we need to learn more about.
Yeah, absolutely. I've definitely had patients where I give them their options and they ask me what they should do. And I'm like, no, that's why I explained the options so you would decide. I don't want to decide for you. So I definitely sympathize with that sentiment. It's definitely something we need to work on.
Thank you.
Hi, I'm not a physician, and your research is very different than mine, but I really liked your presentation. And this goes, I think you've answered my question maybe already. This goes to what Jim was saying when he was on the patient advocacy panel the other day. I have a question about strategies to identify advocates within the community that can help you increase enrollment. What are the strategies you talked about, maybe church and other community groups, but how do people that do your type of research strategize to achieve that?
So I'm obviously very early in this type of research, so a lot of it has just been people who know other people. So clinicians or practitioners who have been doing it for a long time tend to know people in the community or resources. So for me, it's really been kind of working off of people who just have a lot more experience than me, and those people might be able to answer that question better. But yeah, it's been a big learning curve for me.
But I would think, yeah, once you have those people and you have that network, I mean, as your research goes further and deeper, I mean, that's going to be really valuable for you.
Yeah, hopefully.
Thank you.
Thank you.
Thank you for the wonderful presentation. I think it's a really very, very important study, and I think it's very important that you're kind of this independent third party asking these kind of questions. I've been a Beacon survivor to survivor volunteer for the last couple of years and speak to a lot of patients, and I can tell you that they share their fears, concerns, and questions with us that they would never share with their surgeon. And I just hope that when the study is finished, that maybe we could arrange to have you come and present the results to the group of survivor to survivor volunteers. I think it would give us a really important perspective that will help us.
I'd love that. Reach out to me on the app.
Okay,
Yeah, great.
Let us know when it's finished. Thank you.
Thank you.
Hi, Ava. Very nice work.
Thanks.
I'm Karen Sachs. I'm a patient advocate as well as a nurse navigator, and several years ago had a Spanish-speaking patient and had very few resources for them. Thankfully, Beacon has now translated many of their resources into Spanish. I also want to just put a plug in that when your decision aid gets translated, please put that out widely, because all of us really need that.
Yeah, absolutely.
And I also want to say I think you're on the right track in terms of trying to get these patients who are Spanish speaking to them in person, taking advantage of when they are in their clinic visits to to speak with them. And I find that for this population, needing to have some patient community advocates for them to really kind of walk them through the process and help them understand at a very basic level is something that's needed as well.
Yeah, absolutely. Thank you so much.
Hi, I'm Bob Schreiber, also patient advocate, survivor to survivor participant. I thank Doug for his suggestion that you talk to us as a group. And I have another thing I'd like to volunteer you for.
Okay, great.
Which is Beacon has a survivorship task force, and everything that you presented matches very well with many of the subjects that we've talked about. So after this session and when there's the get-together session, if you could maybe either see me or, more importantly, talk with Mary Dunn as well as Christina Amodi. They are the co-chairs of the task force. I think it'd be really great to have you as part of that.
Yeah, I would be honored to help in any way I can.
Good,
Thank you for bringing
And you're
that
going
up.
to Tennessee, which is the next state over to North Carolina. That's where Mary is, so it can't be too far away.
Okay, perfect. Yeah.
Yeah, we come from Boston. Every state is close.
Yeah.
The other thing I wanted to sort of ask you about is, ask a question is, somebody mentioned AI as helping out, and certainly over the next few years, we're going to get into the realm of having instant communications between people of different languages. How do you think that's going to improve the situation, or are there still, truly significant barriers, like in terms of translation of, written documents, and even with the spoken word, are the cultural and societal barriers still so significant that we'll still need to have somebody who really understands the language?
Yeah, I mean, I think that's a whole talk on its own, but a lot of the issues with AI is that it doesn't understand yet, or I don't know if it will, cultural, societal experiences, things like that. So I did, just for my own curiosity, put decision aids into different AI translators, and then when reviewing it, it was either it just didn't make sense. It either directly translated things, didn't conjugate tenses correctly. I imagine all of that will improve over time. or didn't kind of get the spirit of what was trying to be said in that sentence across. I imagine that'll improve over time, but I like to optimistically think we'll always need the human touch to kind of influence patient aids in terms of, making it understandable for that patient despite their language or cultural background, things like that. So I think it could help, but I think we'll always need, patient and clinician input.
Okay, thank you.
Thank you.